Yes, my name is David Boehner. I am at Ohio State University. I'm an associate professor of emergency medicine. Well, briefly, what we've done at Ohio State is that we've realized that the technologies outpace education, meaning the technology continues to get smaller. It's at the bedside, but yet there is not the requisite education for the operators to use this. We've tried to integrate this into the 4 years of medical school. In the first year, during anatomy, they receive lectures, and then during cadaveric time, when they're dissecting the cadaver, they'll actually put the ultrasound probe on and look at the head and neck, look at the musculoskeletal system, and look at the abdomen. Then in their second year, we are training them to use ultrasound phantoms in a skills lab scenario where they can guide a needle into a vascular phantom in the hopes that they will be able to do ultrasound-guided procedures in the future. In the third year, we give them exposure to different scenarios that they may encounter, such as cardiac arrest, how to look at the heart with ultrasound and make decisions, the patient that's hypotensive, how to use ultrasound in the patient that's in shock, using a phantom that is a pregnant phantom. It's made by Blue Phantom. They can do a transvaginal ultrasound in a skills lab and learn the technique on how to interrogate the pelvis and detect intrauterine pregnancy. And then we have them screen simulated models to look for AAA, abdominal aortic aneurysms, because ultrasound is very helpful in that setting. In their fourth year, they have a similar experience during a Doc 1, a differentiation of care, where they will get experience doing those same type of ultrasound procedures. And then we also have an honors program, an elective program that's a longitudinal curricula that they learn 11 focused ultrasound procedures during their senior year. And these students will then graduate with skill sets that they take into residency, and that they are a little bit ahead of the curve. The American Medical Association on December 7th, 1999, in their House of Delegates, they voted on an amendment, House Resolution 802, that basically said that ultrasound is the proprietary of each individual specialty, so each specialty has to define their scope of practice. And each individual, based on their specialty, needs to apply for privileging to their individual institution. Why this was important was that in the 90s, there was a lot of turf battle between radiologists that would say that people that are using ultrasound would have to adhere to their standards according to radiology. With this House Resolution 802, what it basically said was each individual just has to abide by their own specialty scope of practice. They followed that up in the spring of 2000 with House Resolution 108 that basically said if you are credentialed to perform ultrasound at your institution, then you're able to bill for it. What the ACEP, the American College of Emergency Physicians, came out in 2001 is with this lead, they came and developed their scope of practice, what emergency physicians would have to do to adhere to a scope of practice for emergency clinicians. Not all specialties have an ultrasound scope of practice, but emergency medicine had 7 things in 2001, and then in 2011 added 4 more, in 2008 added 4 more, so we have 11 focused uses that emergency physicians use ultrasound for. These are, the uses are looking for cardiac activity, looking at the aorta for size, using it for trauma, using it to aid procedures, using it to look at the kidney for hydronephrosis, looking for pregnancy, looking for gallstones, looking at the lung for fluid collection, looking at the eye for retinal detachment, looking at the veins for deep vein thrombosis, and looking at the soft tissue for abscess. So physician, non-traditional imaging specialists that can bill for ultrasound, it just depends on your local institution. You have to apply for privileges through your credentialing board, show them that you have training and that you're able to do this procedure. And then if you're credentialed by your hospital, then you can submit codes for billing. We've just articulated a process at our institution where we submit codes for about 11 different indications here. To do that, you need to have images that are saved, and then you have to have a generated report that you put into the chart. So with those 2 things, with images saved to a record and a report on those imaging exam, you can then submit CPT codes for billing. Surgeons are interested more in ultrasound. They've been interested in since the mid-'80s with the FAST exam, the focused assessment with sonography trauma, looking at the trauma victim and do they need to go to the operating room. If they're unstable and there's fluid in the abdomen, they will take the patient to the operating room. A new surge of interest has gone on over the last 5 to 6 years with critical care. So in the critical care environment, not only the surgical critical care, but also in the medical intensive care, when you have patients that are in cardiac arrest, in shock, need a procedure done, that ultrasound is at the bedside, do the clinicians know how to use it? And so I think that there's been a lot more interest on the critical care realm for surgeons, anesthesiologists, and pulmonary and critical care. The challenge is that it's not embedded into most surgery programs. There's usually a 5-year program, 60 months. There's not dedicated time in their programs for them to learn how to use this tool. I know that the American College of Surgeons supports ultrasound, and it's in part of their policy, but I don't know if there is the requisite time for the surgeons actually to learn how to use this tool. I think that the time has changed. It's been 11 years since the AMA resolution. I think that there has been a lot more collegiality about this topic. I think locally at each institution that there may be some individual turf. I think that the American Institute of Ultrasound and Medicine is the oldest ultrasound organization. I'm on that board, and it's a board of radiologists, OBGYNs. I'm the first emergency physician to sit on that board. We're really looking on how to work together with the ultrasound community as a whole in trying to use this in a safe and efficient manner so that we can ensure who are the operators and that they know what they're doing. I think that was the main issue with some of the radiologists. They wanted to make sure that whoever was doing the exam knew what they were doing. And I think the turf has lessened, but I think that it's still there at local institutions, depending on individuals. I think that there's been a lot more awareness about radiation risk with CT scans. I don't know if I've seen a noticeable decrease in the number of CT scans that are ordered. I do know that unlike before on the CT scan, there now is one of the images is the amount of dose from that CT scan for that patient, which is new. So they'll tell you how many millisieverts this CT abdomen pelvis expended to the patient. And so I think that we're still in this transition period where the awareness has been there as far as CT scans and the potential long-term risks. I'm not sure that there is the incentives or the disincentives for clinicians to stop utilizing CT scans, because I think a lot of this stems from there is medical uncertainty, not only on the patient but on the clinician trying to figure out what's going on with the patient. And CT scan will help to answer those questions. And so ultrasound, I think, in some cases can be an alternative. For example, the patient with kidney stones, they get multiple CT scans. I think ultrasound can be a nice alternative. But for things like appendicitis, I'm not sure that ultrasound can step right in and give them the diagnostic certainty that they need. So I haven't seen the change in behavior yet, but I have seen the change in at least the reporting of the radiation that is being imparted to the patient.